to another special episode of Tuesday series. Actually, today being the World Liver Day, we have set this Tuesday apart for a World Liver Day observation on the request of our beloved friend and renowned pediatric gastroenterologist of Govt Medical College Trivandrum, SATH Associate Professor Dr. Prashant K.S. So he has been very active in the forefront of pediatric gastroenterology, especially in Trivandrum and also in Kerala. So on request of the pediatric gastroenterologist, we have set apart this day for World Liver Day. As you all know, these the cases of viral hepatitis and also also NASH in pediatric age group is increasing day by day. So this day assumes a great importance. So on behalf of IAP Thiruvananthapuram, I welcome all the delegates who have come here to attend this World Liver Day observation and also to hear the great lectures of Dr. Prof.Dr.SK Yachha, sir, on neonatal cholestasis and Dr.Rajeev Khanna on biliary atresia. So first of all, I would like to welcome our state IAP President, Dr. Vijayakumar, sir, who has come here for the inauguration of the meeting, and our State Secretary, Dr. Johnny Sebastian, sir, then our National Executive Board member, Dr. Riaz, our IAP Thiruvananthapuram Branch President, Dr. Tukmini Madam, then our speakers, as I've already mentioned, Dr. H.S. sir and Dr. Rajeev Khanna, sir, and all the senior leaders, teachers from Kerala and also from Trivandrum and also from outside Kerala. On behalf of IAP Trivandrum, I welcome everybody to this meeting. Now over to President IAP Rukmini Madam for the Presidential Address.
Good evening. Respected State President, Dr. Vijayakumar, State Secretary, Dr. Johnny Sebastian, our NEBM, Dr. Riaz, our Branch Secretary, Dr. C.B. Kurian, and Chairpersons of the day, Dr. Elizabeth and Dr. Sivakumar, and speakers, Dr. Yachha sir and Dr. Rajeev Khanna, all the seniors and friends here. From dedicating this day for liver disease, you all know that April 19th is being observed as the World Liver Day. So what does it mean? It is like to keep the liver healthy by healthy lifestyles. That's the motto behind it. And to increase the awareness among public, this day is being celebrated. Now coming to the pediatric liver diseases, previously we used to say NASH as a group. Now we would like to say it as pediatric fatty liver disease, being the commonest one, that is around 10% of liver diseases in children. Being pediatric fatty liver disease, we give much importance for that. So we are starting an awareness campaign for this pediatric fatty liver disease also. Now that hepatitis B is under control somehow, we would have to concentrate on other problems like fatty liver disease, why it happens, the main being central obesity and insulin resistance, which can be tackled by proper awareness and proper measures. It needs a special consideration. Me being a general pediatrician, I have always had a doubt, which I would like to present in front of the renowned gastroenterologists. Are we getting all these liver diseases because of the over-the-counter drugs like acetaminophen, which is being used more and more during this last few years, last few decades? And is that one another important cause which we can prevent? And also that additives, preservatives used for the junk foods and outside foods, how much they are contributing. I request you all, the gastroenterologists, to ponder into this question and do a research and come to an answer for that. Now, let us all fight liver disease by giving awareness, and also let us all stand along with all those children who are having liver diseases. Let us support them for the fight against liver diseases. Thank you very much. Thank you all. Dr. Prashant? Dr. Prashant, അടുത്ത ആൾക്കാരെ വിളിക്കാവോ അല്ലെ ശാലേ? Prashant mute ആണ്.
Mute ആണ്.
Or shall I call or Dr. Prashant?
Madam, I can hear. Just 1 second, madam. I think for the inauguration and launching of the awareness campaign against fatty liver disease in children, I invite our state president, Professor Vijayakumar sir. Over to Vijayakumar sir.
Respected Dr. CB, Dr. Rukmini Madam, President of IAP Thiruvananthapuram, Dr. CB, Secretary IAP Thiruvananthapuram, Dr. Riaz, NEBM member, Dr. Johnny Sebastian, President, Secretary of IAP Kerala, and the man behind all our presidential action plans, Dr. Prashant K.S., Dr. Ramakrishna Kumar, President of Gastroenterology Chapter, Elizabeth Madam, Sivakumar, and the respected speakers, Dr. Yachha sir and Dr. Rajeev Khanna, Dr. Benno, and all our friends of IAP Kerala. Today is the World Liver Day. The purpose of this day is to raise awareness about liver-related disorders. At any cost, we should screen for liver disease in children, diagnose it early, and send them for ideal management at correct time. Meanwhile, we should aim for preventing the development of acquired liver disease, mainly non-alcoholic fatty liver disease, occurring as a part of lifestyle diseases. The main interventions to prevent liver disease in children are either eating a well-balanced diet, doing adequate exercise, avoiding alcohol and hepatotoxic drugs, immunization, and early diagnosis and appropriate management. Somehow I feel that early diagnosis and optimal management of liver disease is taking a backseat compared to congenital heart disease, hypothyroidism, and other diseases in Kerala. So, for example, congenital heart disease, we have a Hridyam program. So immediately after delivery, we are doing the pulse oximeter screening, diagnosing heart disease early, and sending to the hospitals, surgical centers for correcting it. This is not happening in congenital liver disease. So IAP, Indian Academy of Pediatrics, Kerala State, in this presidential action plan of promise 2022 to prevent acquired and in its acquired liver disease by in its action plan preventing non-alcoholic fatty liver disease, and it is being kick-started today. So I request the stakeholders of the pediatric gastroenterology team. Can you hear me?
Yes, sir. Please,
Yeah.
please.
So in this occasion, I request the stakeholders of the pediatric gastroenterology team from Kerala to formulate a project for screening, early diagnosis, and proper management of pediatric liver disease. So we can discuss it at the government level and include in the priority program, like we did in Hridyam, newborn screening, and Mithai program for diabetes mellitus and all. I wish the CME a grand success, and I am formally inaugurating the program. I also inaugurate the flyers. Thank you. Jai Hind and Jai IAP.
Sir, kindly release the flyer also, sir.
Yes, I'll just formally releasing the flyer. Can you just show the flyers?
Sir, actually, I am.
Okay, no problem. So along with this program, I am inaugurating the flyers also. I'll just send. I'll send to the
I think
respected groups now only.
Before Yachha sir's talk, you can show it. You can load it and keep.
Yeah. So I'll do this. Formally, I'm inaugurating that also. Thank you. Jai Hind and Jai.
Madam mute, Anne. Madam mute.
Thank you, Vijay Kumar sir, for inaugurating the program, as well as releasing the flyer for the fatty liver awareness campaign. Now, to deliver the felicitation, may I call upon Riyaz sir, National Executive Member, Central IAP. Over to Riyaz sir.
Respected State President Vijay Kumar sir, District President Rukmini Madam, and most beloved guests Yachha sir and Rajesh Khanna sir, and all my friends and teachers here. As Vijay Kumar sir rightly told, this is one chronic disease in children where we pediatricians should develop some protocol to identify early. Because like in the case of kidney diseases, many of our children with kidney disease in the past were diagnosed only when they are ready for dialysis or a renal transplant. But with the increasing awareness, we are all aware of screening for congenital abnormalities of the kidney or bladder or ureter whenever a child presents with UTI and things like that. Like that, every jaundice should be evaluated. Every telltale signs of metabolic liver disease in an infant should be identified, as well as it should be screened and evaluated in a protocol-based manner. I think there are very well-developed protocols for identifying and evaluating metabolic liver disease in infants, developed by ISPAGAN, which is already published in Indian Journal of Pediatrics. And we should all popularize all these among pediatricians so that we can identify these children before they are decompensated, and we can help them. So this is a great initiative. Congrats to Dr. Prashant, Rama Madam, and all the torchbearers of Pediatric Gastroenterology chapter in Kerala. And also from all of us, a huge thanks to Yachha sir and team for supporting our Kerala team in a big manner. So thank you everyone, and the best wishes. Let us go forward. Thank you. Prashant mute ane. Prashant mute type. Prashant.
Thank you, Riyaz sir, for the kind words. Johnny sir, our Secretary, IAP Kerala State Branch, has informed that due to some personal commitments, he cannot join the meeting. I think we will complete the official formalities, and we'll go to the scientific program straight away. May I call upon Elizabeth Madam to... Elizabeth Madam is my own teacher and mentor. I call upon Madam. She is presently Professor and Head of the Department of Pediatrics at Sri Mugambika Medical College, Kulashagaram. Besides, Madam is the consultant to UNICEF Kerala State. I request Madam to introduce the first speaker of the day, Professor Yachha sir.
Thank you, Dr. Thank you, Dr. Prashant, for the kind words and this invitation. Every year, meticulously, you are doing this Liver Day and Gastroenterology Day and all, and we are really proud of you. Actually, when we were postgraduates, we never had any help from a pediatric gastroenterologist, and we used to take our cases to the adult gastroenterologist, and our children never cooperated for any procedure, and they used to say, one of you get trained and look after these children, don't bring them here. They scream and they spit on the doctor and all those things, and it used to be a big nightmare for us. And I'm very happy that we are dealing with the neonatal cholestasis and neonatal hepatitis. Especially, we have less awareness about that. And yesterday we were reading in the newspapers that a rare new disease is coming among children in US, UK, requiring even liver transplantation, which happens to be adenovirus. So new threats are coming, and as the previous speaker said, we must be very much alert about all these liver conditions, and we should have definite protocols for early diagnosis. And coming to my pleasant duty, before that, I thank the organizers and IAP Kerala, IAP Trivandrum for this wonderful day being observed. Even though it is on webinar, most of it's a large crowd which has come in, and I'm extremely happy and I feel proud to introduce Professor Surendra Yachha sir. We used to listen to you, sir, during the Pedicon, and we cherish the lectures that you have given. So, sir had MD and DM gastroenterology both from Chandigarh, and after that, sir was awarded Commonwealth Medical Fellowship and had training in hepatology and liver transplantation from the prestigious King's College Hospital, London. And currently he's the director and head of the Department of Pediatric Gastroenterology, Hepatology and Liver Transplant, and head of the Sakra Academics World Hospital, Bengaluru. And sir is a very distinguished and illustrious academician, formerly from the STPGI, Lucknow. And sir is the founder president of Indian Society for Pediatric Gastroenterology and Nutrition, ISPAGAN, chairman of Pediatric Gastroenterology Subspecialty of IAP, then president of Indian Society of Gastroenterology, and so many firsts are there for sir. Started the first department of Pediatric Gastroenterology in India. The credit goes to sir. Started the first DM Pediatric Gastroenterology training program in India, and sir has been awarded ICMR Research Award, the highest award of Indian Society of Gastroenterology, that is the Chutani Oration, and Shandilal Seth Oration, the prestigious highest award of Indian Academy of Pediatrics. And I'm sure some of us would have, many of us along with me would have listened to him in 2020. And sir has a lot of publications, more than 200 to his credit, 35 chapters, and is a reviewer of most of the Indian and international journals. And we are very fortunate and very happy to welcome you, sir, to share your pulse of wisdom with us on this auspicious day. And I'm very happy that Dr. Prashant and Rama and Rukmini and the whole team could get you at least on Zoom for us on this day. Thank you very much, and over to Yachha sir.
Can you see my slides?
Yes, sir. Yes, sir.
Respected Professor K.E.Elizabeth, Chairperson of my session, Dr. Vijay Kumar, Dr. Riaz, Dr. Prashant, and most importantly, Dr. Rukmini. It's a great pleasure to be with you on this day. I was very, very thrilled to hear all of you that your tremendous interest in liver diseases in children, which is the need of the hour. Let me tell you briefly that pediatric liver constitutes nearly 33% of all disorders in GI practice, 33%. And pediatric liver is much more difficult as compared to the adult liver. I have been telling in all the Indian Society of Gastroenterology, INSL liver meeting the same thing. It's not easy to diagnose the conditions in children as well as treat these conditions in children. They need huge laboratories. They need huge clinical equipment. So they accept it. And because the adults have a couple of disorders which can be easily diagnosed, not difficult to diagnose. But children, a Pandora box, the huge disorder gamut. Now today I have been given the job of neonatal cholestasis And the title of this particular topic is Neonatal Cholestasis, Unmet Needs and Advances. Very, very aptly chosen by Dr. Prashant, I think. Very important lecture. From state to state, from neonatology to pediatrics, people have been demanding on this subject, probably because it seems to be confusing at times. And in 1990s, let me tell you that we were all confused ourselves what it is. It was the picture in India was dismal, distressing, and depressing. And thereafter, we took the reins and we started looking at this condition as pediatric GI people. It is a mixed bag of disorders. Jaundice, passage of dark urine without alcoholic stools. So this is a heterogeneous group of disorders. There's a different treatment, variable outcome for all these entities. Now, what we see, there are two distinct entities. One is the obstructive variety, that is the biliary atresia and colorectal cyst, which constitutes nearly 43% of total in India. And we have got intrahepatic disorders, which are familial, metabolic, infective, and there may be paucity of bile ducts. My dear pediatricians, it is not difficult to diagnose this condition if we have a straightforward algorithm in mind and we know what we are looking for. Generally, there's a clinical overlap between these two entities. When we look at India, this is the data of 1008 cases which we accumulated in 1999 from different centers, medical centers, and also from the surgical centers. We found that 9 centers, medical 9 centimeter, the centers, and we found the distribution. Biliary atresia 34%, colorectal cyst 4%, and hepatocellular causes 53%, ductal paucity 3%. And this was the overall. We had no data at that time in India. And thereafter, when we looked prospectively, we found 216 cases at IGP Lucknow. Look this slide. You'll find that the intrahepatic causes and biliary obstructive causes. Biliary atresia tops the list, and colorectal cyst also is there. Around 44% of cases were of biliary atresia, which Dr. Rajeev is going to tell you. And in the intrahepatic group, you find galactosemia, neonatal sepsis, you'll find Alagille syndrome, intrauterine infections, very small proportion, progressive familial intrahepatic cholestasis, tyrosinemia, and also a group which is 40 cases out of these 105 idiopathic neonatal hepatitis. So this is the distribution. We are not to read the textbooks or the journals to go into the rarer disorders. Leave it to the pediatric gastro or hepatology people to find out. If we don't read, this was the situation even in 2000 year, rapid downhill course of these infants, limited options. And the most important reason for this, you can see the veins in the abdomen, ascites, and just an infant which has gone into decompensation. And you see the single most important reason for this was that the pace of the pediatricians to refer up to the appropriate settings was very slow. It was a road roller pace. That was the reason. With the result, they would decompensate and they could not be salvaged thereafter. In 2000, we published our consensus meeting. This is the document which is published in Indian Pediatrics. And this is the same thing where we actually deliberated for 2 days at IGP JMS, collected the whole national data, and then formed an algorithm for pediatricians or the pediatric gastro people to follow. This was at Hyderabad, 2000. You can see here very early in 2007. We also launched, this was by King's College, Georgina Miliburgani, professor. She launched this poster, I also want to live, doctor. This was a poster for biliary atresia, that on behalf of the child we were writing, that my tube is blocked, my liver is on fire, I need knife for surgery. And what knife? Appropriate. When we collected the data, Dr. Elizabeth, I'm just telling you, making you aware, when we collected the data of surgical cases, we found 30% negative laparotomy rate of patients who were operated presuming that this is biliary atresia. 30%, and that too from prestigious institutions of the country. And that was very important, that we should develop a good algorithm for the children. This was second time, 2014, another consensus was created for neonatal cholestasis in India, again published in Indian Pediatrics. Now, clarity in approach. We are in the clinics, we are clinicians, we are not researchers primarily. See, jaundice, dark urine without cholesterol. 14 days of age, generally we take it, but it can be rare also. Serum bilirubin conjugated. First, we should give vitamin K. Never forget, irrespective of etiology, vitamin K should be given to all the babies who have jaundice and high colored urine. Why? Because they're prone to intracranial bleeds. They can bleed and they can die. And therefore, before doing anything else, I think we should give a vitamin K there and then at that time. Second, urine color, very important. See, it should be staining the diapers and the stool color. Urine color, whenever the urine is dark in color, it means it's a liver disease. We have overlap of unconjugated jaundice with the conjugated jaundice. Unconjugated jaundice in children, in babies, in newborns is quite common, and urine will be clear in those patients. Here, the urine is dark color. That is why we say this is a liver disease. And then with the stools also we see whether they are pale in color or they are yellow in color. Sometimes there may be difficulty in distinguishing, which I will tell you later. So you have to look at the urine color first and also the stool color. Now, liver function test for pediatricians, very clear thing. Liver function tests do not differentiate between intrahepatic cholestasis and extrahepatic cholestasis. That means biliary atresia and neonatal hepatitis, what we presume, cannot be distinguished. Nothing can be distinguished. They may be elevated, they may be normal, but generally bilirubin you will find is elevated. But gamma GT may be high. Gamma GT should always include in liver function test. Never forget to include gamma GT. And it is usually high in biliary. So there may be some indicators. High gamma GT also is found in PFIC, progressive familial intrahepatic cholestasis 3. So forget about PFIC 3. I'm not worried. I'm worried more about biliary atresia. So this may be, and low gamma GT may be in one condition that is called bile acid synthesis defect. That may be low. It's a very rare disorder. Forget about it. Therefore, this is important that LFT cannot be discriminatory. Gamma GT should be done. And number two, the high transaminases in early neonatal life may be an indicator of herpes infection. So intrauterine infection herpes. Then don't forget to give vitamins, especially vitamin K. Now, further, what we do? We have to establish that this is because of the cholestasis, this is because of the liver condition. Second thing, you look whether the child is sick or not sick. Is he looking sick? Not sick means, not sick is usual story. 90% of them will be not sick. They'll be okay. They'll be thriving. They'll be drinking milk, everything. And they're active, but they're only jaundiced. And look for the stool, whether pale stool or pigmented stool. And usually three samples should be seen And don't believe the words of the mother, whether it is pale or yellow, you have to see yourself. Then the sick patients are those who have got fever, who have vesicles, who have rash, who have anemia, who have sepsis, small date, low birth weight, sick deaths, maternal adverse factors. This should be taken as a sick baby. Not that only poor feeding is there, lethargy is there, but you take these considerations to say that baby has got sickness. Then if we look at this now, in my own write-ups, many times I have written articles on this, I say sick with high risk patients. What are those? Those who have seizures, who have hypoglycemia, who have uncorrectable coagulopathy, who have got early ascites, recurrent early SIP deaths, they will come automatically very quickly to the experts. Maternal history of stillbirths, abortions, pruritus, lethargy, poor feeding, associated fever, anemia or respiratory distress. Then of course they are sick baby. Immediate attention should be given. So we say, what is a sick baby? These all factors constitute a sick baby. It is not only poor feeding or poor activity. They are all sick and they should be looked very intently. I will just show few cases. I will not show many. Here is a case with jaundice, pigmented stools from day 10. This baby, he is 37 days old, and stormy neonatal course, pneumonias, all these necrotizing enterocolitis, sclerema, hypoglycemia, ascites, liver, spleen, and large, both. This baby is quite sick, uneventful pregnancy. And you can see here, bilirubin is very high, and albumin is low, proteins are low, INR, that is prothrombin time, is not correctable. So it's a sick baby. And then we see further ultrasound done, not contributory. Gallbladder is there, good size, contracting well, and there is no lesion. What we do look for the condition, look for non-glucose reducing substances in urine, and that was positive. And Galliput, that means galactose 1-phosphate dehydrotransferase enzyme assay was done, which was low. Now these are the markers. First one is a marker for galactosemia. Second is a confirmatory test for galactosemia, Galliput. Now what do? We do alpha beta protein. It should be done in these patients who are sick. This occurs in tyrosinemia, high alpha beta protein. So it's a screening test for tyrosinemia. Ferritin, why do we do? Serum ferritin should be done to see that neonatal hemochromatosis is not the screening test again. So high ferritin gives you a clue that probably we are dealing with hemochromatosis. Torch VDRL, which was done negative, what we have seen over a period of decades, all the decades, pediatricians give a lot of importance to torch. No, don't give unless you have a suspicion. And having you waste money on that, you waste time on that. So VDRL, this torch VDRL negative is not important unless you are suspecting acute liver failure, where you are testing for herpes infection. Eye examination is done because we have Alagille syndrome, and that was normal. Blood culture was done as a part of sickness. Klebsiella species was found. So this patient, what is the diagnosis? The diagnosis is galactosemia. Very easy to treat. Withdraw galactose from the diet. That means milk which contains lactose, and that is actually that gets digested and forms galactose. So galactosemia is very easy to treat. We have published 22 cases very maybe 3-4 years back. For the first time, 22 cases of galactosemia from India. There was a lag in publication because the enzyme assay was not there available in India at that time, and we could not show large series. And this particular paper attracted editorials, 2 editorials in Indian Pediatrics. So that is the first study and the only study right now on galactose, very good outcome in these patients. So galactose-free diet or breast milk and everything at 1 year follow-up, you can see this child who had a stormy course became normal. You see another child, just a glimpse, day 40, neonatal liver failure, sick baby, and ascites, organomegaly, coagulopathy, INR of 4, very high. Normally it is 0.9 to 1.2, and 2 similar SIV deaths. So that is why I say SIV deaths should be taken as a sick baby. Ascites, seizures, coagulopathy in this child. And what happened? There was also cataract. Always look into the eyes of the babies. Cataract will be a very good marker for galactosemia. And then urine positive for non-glucosal reducing substances. Galliput was absent. Child was diagnosed as galactosemia. Complete withdrawal of lactose from the feeds, breast milk and the formula milk, and this baby became absolutely dry. And you can see here, this is baby at follow-up of around 6 years. 6 years of age. Absolutely normal child. So galactosemia is quite rewarding. That is why it is important. You see the growth parameters, very good. Another child, jaundice, pale stool. Pale stool, I said, is an indicator mostly if it's a consistent indicator of biliary atresia. Think of biliary atresia first. Diaper staining of urine from 2 months of age, pruritus from 5 months of age, and isolated mild gross motor delay, no significant antenatal or family history. This is cholestasis. Whenever there is a dark urine, jaundice, and also there is pruritus, then we call it cholestasis. And this child has different diagnosis. This can be Alagille syndrome. This can be neonatal sclerosing cholangitis. It can be progressive familial intrahepatic cholestasis. This is the picture, the face showing number of facial dysmorphism, that is of Alagille, as you can see here, and all classical, microcapillary, high arch palate, delayed dentition, prominent forehead, maxillary hypoplasia, liver enlarged, soft spleen present, and one systolic murmur in second intercostal space. So this child had a systolic murmur. Investigations, high bilirubin, high gamma GT, ultrasound as usual was normal, not showing any problem with the gallbladder, and reducing substances as a routine we do. These tests should be routinely done. And alpha beta protein ferritin normal. Eye examination shows posterior embryotoxon, which is a feature of Alagille syndrome. X-ray dorsal spine showed notched vertebrae, half vertebrae, hemivertebrae, what we call butterfly. That's again shown in Alagille, lipid profile high, and echo showing peripheral pulmonic stenosis. So there is nothing left. The book picture and liver biopsy done, we showed paucity of interlobular bile ducts. So final diagnosis, Alagille syndrome, had pruritus which got controlled on UDCA, LFT near normal, but pruritus was difficult to control. This is the problem in Alagille syndrome, where the quality of life may be affected and you have to control their pruritus. Third case, pigmented stool. Day 18 of life, jaundice, high colored urine, not sick, icterus present, all consecutive stools, pigmented stool, liver and spleen enlarged, soft in consistency, ultrasound normal, and all of the tests showing normalcy, and you can see bilirubin is high, and enzymes are moderately elevated. So lipid profile, echo, torch, eye examination, ferritin, alpha beta protein, normal. Liver biopsy showing giant cell transformation. And this was a case, what is called the idiopathic neonatal hepatitis. But I never label any case at the presentation or after diagnosis as idiopathic unless I generally go for follow-up in these patients. Follow-up means their spleen should regress, their bilirubin should become normal, their hepatomegaly should go away, and transaminases should also normalize. That is a time, and it may take a long time, maybe a year, 12 months time, to normalize. And then at that stage, you can say this is a idiopathic neonatal hepatitis. There's a group of, you have labeled neonatal hepatitis, but 10% of them may go actually into some kind of syndromic diagnosis. So therefore, normalization of all these features have to be demonstrated before you label idiopathic neonatal hepatitis. A sizable group on increase in India, diagnosis being increasingly found, progressive familial intrahepatic cholestasis. I need not to, you should not remember everything about it, but there are types, 3 types as of now, which are definite. And there, the type 1 has got first decade it will appear. Pruritus is severe. In all the 3, there can be pruritus, growth retardation. What is important for PFIC1? Associated diarrhea, deafness, respiratory symptoms, pancreatitis. So any child with jaundice and diarrhea who comes, always think of PFIC1 may be there, and at 4 or 5 months of age they will have pruritus, again showing that this is a progressive familial intrahepatic cholestasis. But PFIC2 is very rapid. They go into cirrhosis very fast. So 1 year of life, they have got established liver disease. And PFIC3, although known at older age, may be there. So there are 3 types, generally PFIC1, 2, and 3, and increasingly being diagnosed in India now. So efforts done towards unmet needs, what Dr. Prashant had asked us. Data collection in India, we did. Lacunae identified there and then in year 2000. Consensus statements published. One was 2000 and 2014. Awareness at doctors level in many states in India, I must have delivered not less than 70 or 80 lectures on this entity, and greater demand all the time from different parts of the country. Neonatology also, people, they ask about it. Diagnostics, lab, and applications improved. People started looking at stool color. People started doing at LFTs, doing gamma GTs, doing INR, giving vitamin K to them, and also many centers started doing liver biopsies in them. Normally, our surgical colleagues, they are reluctant to do the liver biopsies. They will take pale stool, they will do HIDA. I don't believe in HIDA, but Dr. Rajeev Khanna is going to tell you about that on biliary atresia. So this is the effort done towards unmet needs. So far, we have done this much, but many issues still hang despite progress and effort. So we have sown the seeds, we have progressed a lot, but still we have not reached the goal. What is the goal? Further, recognize, I tell all pediatricians, recognize neonatal cholestasis clinically. You need to see high colored urine, diaper staining, and lab test showing conjugated jaundice in an infant. Diagnosis has to be made, otherwise you are landing in disaster. Pathways of management are different for different disorders. Do not hold the patient with you with the hope the child will improve. This is an experience all through the country. My own experience in Lucknow also, in Chandigarh also, in Bengaluru also, they try to hold the patient with them, hoping that sunshine and some medication will improve the jaundice. But that is not the story in them. And that is a sort of disservice if you hold the patient with you without diagnosis. Theek ho jayega, child will get well. No, that is not the reply for them. Disservice to children. Laboratory lag to be eliminated. Since there are specific tests which have to be yet, there are problems. We have number of problems in lab tests, which I will not, this is not the topic of today. The validity of these tests has to be established. And I would appeal to young super specialists of our country to have to exert their efforts to get these lab tests done properly in India, establish specific tests for different kinds of liver disorders. Today's world stands changed. Majority are solvable conditions in neonatal cholestasis. Earliest possible referral to pediatric gastroenterology should be done. Don't hold the patient. Awareness at family level, what our Kerala IAP dignitary said, mother in particular should be made aware. Now, how do we do? So, are you listening? Prashant? Prashant? Are you listening, Dr. Elizabeth?
Hello.
Yes, sir. Yes, sir. I was mute.
Okay.
That is why. We can hear you, sir. I think
Okay,
Dr.
okay.
Prashant has some internet issues.
Okay, okay. So now you see the concept, how we can take it to the family. So concept of integrated neonatal cholestasis card for India. This is for UNICEF also. I approached a long time back, 2 decades back, our UNICEF chief in Lucknow, and he was kind enough to listen to me on this aspect. But now that we are ready with the card, UNICEF should give due consideration to this for incorporation into their program. Now, what is that card? We have developed this is the urine panel that shows on this card. This is a prospective study which is very well done and validated and published now. And here you can see the urine panel which shows dark urine. So any baby having dark urine, if the mother is told that your baby passes dark urine consistently, the liver is affected. So it goes quickly to the doctor or pediatrician. Number 2 panel. Panel 2 shows stool color which is pale in color. Pale. What is that pale color? So this is the panel of pale color. There is panel 3, the stool color which is pigmented. Now the urine color addition. Taiwan is a famous stool cord all over the world. And I took the help of my Wei Chang professor from Taiwan. And I took for the referral purposes, I took permission. And you can see here in this card, particular card, I added urine color. Very important. How do we identify cholestasis? It is not stool color is for basically for biliary atresia, but urine color is for overall neonatal cholestasis. We also added 7th color, not classified in Taiwan card, pigmented. That was here in this panel. Excellent inter-item correlation and between the parents and fellows. This was done on a large number of patients, and samples, which was done blindly, and promising new tool for early referral can be this card. If Taiwan could change the fate of biliary atresia, we can change the fate of neonatal cholestasis in this country by incorporation at the family level. Now, what has changed in last 10 years for neonatal cholestasis? What is new in this? What Dr. Prasad is, what are the advances? Advances are many. Shrinking idiopathic. Normally we would say 60%, 40% idiopathic. Now this is shrinking because new laboratory tests have come up. Genetic applications have been used. Diversification in bile acid transporters have been demonstrated. And phenotypic expression of sclerosing cholangitis has been demonstrated. You need not to remember everything, just to show you. And better screening tools have been shown clinical utility to be reproduced. This is to be reproduced. A lot of things are being done, which I will show an example. New drugs have been used for pruritus and cholestasis, may replace need for biliary diversion and liver transplantation. Bile acid synthesis disorders have been demonstrated, and the therapy has come up to some extent. New presentation of diseases, that merit differential diagnosis. So these are overall. For pediatricians, I don't think there's the need to remember all these things, but since it has been asked, so therefore I'm supposed to tell. What has changed in the last 10 years? Again, screening, diagnosis, outcome and therapy. Novel ideas on screening have come up. Then you can see the new entities, diversification, clarity, natural history of many disorders have come forth, and genomics, basic sciences have also improved their understanding. Now here I would like to show you, this is a clinical approach and priority for screening. And here in this particular study, persistently pale stool meant to problem of we have to look for biliary atresia-Diagnosis. Fine, that is clinical, not genetic or anything else has to be done. And others out of these pale stools where biliary atresia-Diagnosis were excluded, family history, pruritus, early decomposition, or with pigmented stools, no obstructive causes, ultimately genetics identified them. Exceptions being galactosemia, homochromatosis, infection, they can be diagnosed by other methods, other tools rather than genetics. Genetic analysis has become very common these days. A lot of pediatricians, they are advising genetic counseling. This genetic analysis. One is single confirmatory gene testing, where you know I have to look for this and confirm this test, that is called the single gene. And cost is around 5,000 to 8,000 in India. Most commonly used panel testing, clinical exome sequencing, and where you have a set of disorders and you want to find which one it is. And the cost is around 20,000, 25,000. And whole exome sequencing is also done. The cost is very high. This is arrow in dark. When you don't know what are you dealing with, you do whole exome sequencing, which is expensive. And mostly people do what is called clinical exome sequencing as of now. Advantages are many. Mostly definite diagnosis you will get in 4 to 6 weeks time. That is turnaround time in India. Closure for the physician, what is the diagnosis? Predicting patient's outcome. When you know the disease entity, you can predict the patient's outcome. This identification of heterozygous donors prior to OLT. Suppose you do transplant, you want to do this father or mother wants to donate. So we must know that time what is the genotype. Genetic counseling, antenatal diagnosis, yes, and maybe gene therapy, which has not come easily so far. Now here you see how screening, just little example I would say, is 2021 article, 2,000 samples nearly in children, and in 3 days time they found 27% definite pathogenic mutation, 3.6 had likely pathogenic, large proportions of variants of unknown significance. So many disorders can be identified. So this is an attempt to find out, can we use gene panels to find out, sequencing panels to find out the variety of disorders. I said our progressive familial intrahepatic cholestasis 1, 2, and 3. Now recently 4, 5, 6 have been identified, but they are quite rare. You need not to go into the depth of these. You refer them to the pediatric gastro group wherever you have difficulty. And then lastly, bile acid synthesis defect is very easy to diagnose. What we should do, any child having jaundice, progressive, and has got malabsorption, diarrhea, very importantly, they may have bile acid synthesis. So there you can do bile acid levels, and they may be very low, and that is a synthesis defect. And that may be a sizable number can be treated with cholic acid. Cholic acid is available, and you can procure it, and patients become reversed, and they have very good prognosis with cholic acid. Then we know that therapeutic targets are many. This is all the hepatic targets, particularly liver, and lots of transporter proteins to target. Now, there new drugs in cholestasis have been tried. because pruritus is a frustrating presentation of many disorders in infantile cholestasis. And out of these, sertraline and 4-phenylbutyrate have been approved by FDA. Rest are not approved by FDA. And I would like to tell you briefly few things about this, what is the drug 4-phenylbutyrate. For type 2, it has been found to be effective. For type 1, partially effective, but not really conclusively proven to be of great use. Sertraline reuptake inhibitors, again for pruritus Alagille syndrome, small number of patients, but not really promising. And this is a promising drug which is called maralixibat, and is a potent inhibitor of ileal biles. Where ileum bile acids are absorbed, so the transporter is blocked there, and this has been tried in Alagille syndrome. It's quite beneficial in them. They have found the quality of pruritus, the quality of patients does improve, but long-term studies are required. None yet satisfactory for use except maralixibat, which I showed. So there are many side effects with phenylbutyrate. There are problems with other drugs, but maralixibat so far has been found to be good. So neonatal cholestasis, the enema should discontinue. 3, 4, 5 conditions should be diagnosed, and if you are not able to diagnose, refer them, don't hold the patients. And recognize all entities of neonatal cholestasis. It is not that leave jaundice. Act correctly, act meaningfully, there should be no delays. And I'm very thankful to all pediatricians who are listening to this lecture. I'm grateful to all dignitaries of Indian Academy of Pediatrics, and my great friend Dr. Prashant, who is a pediatric gastroenterologist. I'm grateful to them for this lecture. Thank you very much.
Thank you, Yachha sir, for that nice introduction, as well as you took us through the history and from the basic to the latest. And I think the simplest message, that is the mother's card.
Yes.
That is the one, I think.
There you should help us.
It is not because the parents are not noticing or they are not bringing it, but
Yes.
the correlation between the urine color and the motion color. It should be pale urine and colored stool. And when there is a deviation, and the echolic stool need not be always there. That is the point that sir was trying to tell us. The color of the urine, I think that should alert us, and we should never tell that it may be breast milk jaundice or this and that. It will go away and like that. And we see that many are diagnosed very late, and the correct diagnosis and treatment they are not getting. Let me see if there are any questions. One is, how is rifampicin helpful in the neonatal cholestasis?
Rifampicin, see, the patients who have got pruritus, itching, there we give UDCA. Hello. There you give UDCA, ursodeoxycholic acid, and maximum dose 30 milligrams per kg body weight per day, and see the response. If the response is not great, partially improvement, not complete improvement, then you should add rifampicin. Rifampicin 10 milligram per kg body weight can be added. Even if there is no response to both these drugs, there are situations, then you should add cholestyramine, right? And that binds the bile salts, and it may improve. But despite all these three agents, you may still have a sizable proportion, 20% of them having pruritus continue. So what do we do for them? We should do biliary diversion. Although biliary diversions are not shown to be conclusively proven for all the types, but they may have. And that is why a new one, I showed you that receptor blocker drug. That is a promising drug that may help us, and it may stop actually the bile acid absorption from the ileum, and stop from doing biliary diversion or transplantation. Transplantation generally for eligibles or those who have pruritus is generally done for quality of life rather than the liver dysfunction. It is uncommon to find liver dysfunction in them, but quality of life, for that you have to do this thing, and also xanthelasmas they develop. So you have to do for that.
Dr. Riaz has given a very practical suggestion that this can be the stool and the urine chart can be included in the MCP card, the mother child protection card. I think that is wonderful. That chart already is having so much of information. This will really help. We know the neglected cases when they come to us and how badly we feel. The parent has been showing or telling about this many times, but the correlation was never done. May I request Dr. Riaz from Calicut? Dr. Riaz?
Yes, sir. Yes, sir.
Where are you?
Remarks.
Your face is not seen.
Sir has joined, but he is not unmuted.
Okay.
There are no more questions. I think, sir, can you please stop the slide share?
Yes, sure. I will.
Thank you very much, sir, for that.
Thank you very much. Thanks.
Wonderful
all
symbol measure that you have given us.
Thank you very much.
Dr. Riaz, can you hear us? Can you please unmute?
Riaz sir.
He is enjoying the winds of Calicut.
Hello, sir. This is that fast breaking time. Probably sir had informed me that he may be late in joining.
Okay.
Yes, sir. ഒന്ന് വിളിച്ചു നോക്കൂ പ്രശാന്ത്, ഇടയ്ക്ക് എപ്പോഴെങ്കിലും ജോയിൻ ചെയ്യാൻ പറ്റുമെന്ന് ചോദിച്ചു.
Okay, ചോദിക്കാം. I think, Yachha sir, the biggest message today may be the incorporation of our indigenous stool urine color chart into our MCP card. That is the, I think, felt need of the hour. Hope the message is conveyed clear and loud.
Yes.
Dr. Vijay Kumar, President, please give your remarks. Dr. Vijay Kumar, before we conclude the session. Okay, we can proceed, I think.
Thank you, Yachha sir, for that insightful lecture.
Thank you very much.
Now we should move to the second session. Sivakumar sir.
Prashant, I am here.
Sir, can you please switch on the video?
Yeah,
not
right.
Okay. You are not visible. Thank you, sir. Now may I welcome Professor Sivakumar sir, who is the head of the Department of Pediatric Surgery in our hospital, SATH hospital, to introduce the next speaker and the topic. Over to Sivakumar sir.
Thank you, Prashant. Next talk is on Biliary Atresia-Diagnosis and beyond. And this is being presented by Dr.Rajeev Khanna, who is additional professor of pediatric hepatology at the Institute of Liver and Biliary Sciences, Delhi. And he did his MD pediatrics, and after that he did gastroenterology and had a fellowship in pediatric hepatology, King's College London. So I think he is a very experienced, and his field of interest in the same subject. I am also interested to hear what he has to talk about biliary atresia and diagnosis and beyond. May I invite Dr. Rajeev Khanna to present his talk. Over to you, Dr. Rajeev Khanna.
Thank you, sir. And good evening, everyone. And first of all, I would like to thank Dr. Prashant, Dr. Rukmini, and the team for giving me this invite. And last but not the least, I would like to thank with my whole heart Dr. Yachha, sir. So because of him only, I am speaking on this platform, and because of him only, I am at the position where I am actually at ILBS. So I am heartily thankful to Dr. Yachha, sir. And I am actually feeling very small that I am speaking in front of you. So Dr. Prashant, can I be allowed to share screen?
Yes, please, you can.
Dr. Prashant, it is still disabled. Yeah, I can share now. Yeah.
Okay.
Is the screen visible? Are
Yes,
the slides moving?
Yes, visible and moving.
Yeah, okay. Okay, so I'm starting this talk, the Biliary Atresia-Diagnosis and beyond. So I will give my talk under these headings. What is the need for early diagnosis for biliary atresia? What are the tools? So these tools are like the stool color, as sir has already said, the ultrasound, Doppler, histology, elastography, and what are the composite tests, and what is new. And what is the, and subsequently I will come to what happens after Kasai, natural history, and I will focus on cholangitis and portal hypertension. And in between the slides, I will also talk about what are the indications and timing of liver transplant in biliary atresia. So biliary atresia, as we all know, is a progressive fibro-obliterative disease of the intra and extrahepatic bile ducts, affecting 1 in 8,000 to 12,000 live births. And it's the commonest cause of neonatal cholestasis, as sir has already said. And this is the commonest indication for liver transplant in children. So these are the types of biliary atresia. And unfortunately, the last one, where the whole biliary tree is atretic. So this is the commonest one, commonest variety, which is seen in 90% of overall biliary atresia. So what is the surgical option? Surgical option is Kasai portal enterostomy, where the atretic gallbladder, CSD, and the CVD, so they are replaced and they are connected to the jejunum with a 40 to 50 centimeter Roux-en-Y loop, and after dissecting the porta hepatis. But unfortunately, this sometimes, or in around 60 to 70%, this may fail, and ultimately these children have to be subjected to liver transplant. So how should we define the success of Kasai portal enterostomy? So the success is defined as per various studies in literature on the basis of bilirubin levels when they come down to less than 2 milligram per deciliter, or some studies say less than 1 milligram per deciliter within 6 months. So why the biliary atresia has to be diagnosed early? Because the outcome of the biliary atresia depends on the age at the Kasai portal enterostomy. So if the age is younger, the outcomes are better, up to 60 to 70%. But if the age goes beyond 60 days or 90 days, the outcome decreases to 40%, as seen in this slide. That 90 days, 120 days, the success of a Kasai portal enterostomy is just up to around 30%. But if the surgery is done within 30 days, the outcome may be increased up to 70%. So for early diagnosis, so this slide is applicable for any disease. To make an early diagnosis, that we should be aware of the natural history of the disease. There should be a recognizable latent or early symptomatic stage, and the condition should be an important health problem, which unfortunately for biliary atresia is not still considered. And there should be an acceptable treatment, facilities for diagnosis and treatment, and there should be an agreed policy on whom to treat as patients. So first of all, I would like to emphasize on stool color card, which sir has already said, a very interesting study from SGPGI. So these are the studies from worldwide, from Taiwan, Beijing, Japan, and Germany, where the stool color cards were used. So these are the different stool colors. On the right hand side, you can see the upper topmost, and in the left hand side, you can see that lower 3 colors are abnormal. So for these abnormal colors, the parents are asked to report to their primary health center. So this is a study from the Taiwan, where they have mentioned that before implementation of the stool color card screening and after the implementation of the stool color card screening, so the rates of the Kasai within 60 days, it significantly improved. And also the jaundice free at 3 months, these rates also improved after the implementation of the stool color cards, and also the late referrals decreased to almost half. And this also transformed to the overall survival as well as the native liver survival in these group of infants. So this is another study where they showed that the sensitivity or specificity of these cards are of these stool color cards are very good. So, but there are certain points, like in this particular study, they mentioned that there are administrative issues because the parents have to report the stool color card at 2 weeks and then 1 month and then subsequently monthly till 3 months to the primary health center, and the nursing and the primary doctors have to be trained how to read the stool color cards and what is the interpretation and how to make the proper referrals. So this is again a study from Germany where they mentioned that the distribution was of stool color cards was the major limitation, and there was low acceptance by the primary pediatricians. So there are various differential diagnoses, as sir has already pointed that the abnormal stool color, if the stool is acholic or fluctuating stool color, it may not necessarily be biliary atresia. It may be just neonatal hepatitis, it may be PFIC, choledochal cyst, TPN related cholestasis, Alagille syndrome, or it may be just sepsis. So is the stool color card testing cost effective? So this is a statistical study based on the Markov's model where they have shown that overall we can save the cost. So this is from US where they showed that overall the cost with the implementation of the stool color card in a government setting, it can be decreased to the cost can be saved to around $8,500, and the life years, around 30 life years can be gained with decrease in the number of liver transplants and as well as the number of deaths. So how to screen biliary atresia? So how to look for biliary atresia? So these are the tests. So first of all is the stool color, as I already said, and also I have not mentioned here the slide on HIDA scan, as sir has already pointed. But whatever we see on our naked eyes with the stool color, so that actually is just implemented by the HIDA report. So HIDA is actually used only to exclude biliary atresia when the stool color is fluctuating. But if the stool color is totally pale, so then HIDA may not provide any additional information for the diagnosis, and we may actually waste few more days or around a week or so in doing HIDA scan. So then we come to ultrasound and the Doppler findings. So first and the foremost thing is the visualization of gallbladder. If the gallbladder is not visualized, so then the sensitivity is almost 60 to 70% for the diagnosis of biliary atresia. Then other features are small gallbladder, if it is less than 19 or less than 15 mm, non-contractile gallbladder, abnormal gallbladder wall, then triangular cord sign, which is quoted as a highly sensitive and specific sign for biliary atresia, then presence of subcapsular flow, prominent hepatic artery, or a ratio which is mentioned as hepatic arteries to right portal vein ratio if it is high. So that these are the signs for biliary atresia. So this is a very good study from PGI Chandigarh from 99 neonatal cholestasis infants, where it was shown that the sensitivity of triangular cord sign was not very good, but abnormal gallbladder and non-contractile gallbladder had a good sensitivity and specificity, and they mentioned that a negative triangular cord sign with a normal gallbladder morphology had a negative predictive value to exclude biliary atresia. So this is a meta-analysis of 23 studies on biliary atresia, where overall sensitivity and specificity of ultrasound is around 85% and 92%. So including GB abnormalities, triangular cord sign, and hepatic artery enlargement. And overall absent gallbladder has a specificity of 99% for biliary atresia. So this is a very good study. Point scoring system was defined on the basis of presence of clay stools, triangular cord sign, and a non-contractile gallbladder or a small gallbladder, or with a hepatic artery prominence or presence of hepatic subcapsular flow, and again gamma GT. So gamma GT values, so which have been mentioned in different studies as different values. Some mention as a cutoff of 150 to be suggestive, and some mention as a cutoff of more than equal to 300 to be very sensitive for diagnosis of biliary atresia. So in this study also the cutoff was almost close to 300. And other features were on histology, presence of ductal proliferation, bile plugs, and absence of GANTs, multinucleated GANT cells, which is actually a negative predictor for biliary atresia. So they proposed a cutoff to differentiate biliary atresia and non-biliary atresia. So this is another study from China where they mentioned, where they developed a web-based calculator based on various 7 different parameters. That is the weight at admission, if the weight is good, abnormal gallbladder, triangular cord sign, clay-colored stools, higher gamma GT, and increasing bilirubin, and also albumin levels. So on the basis of this score, cutoff was defined, and this web-based calculator also helped in a very good differentiation of biliary atresia from non-biliary atresia. So this is a web-based calculator which is available online based on all these 7 parameters. So now coming to another thing, which is transient elastography, which is now very commonly used in most of the gastroenterology centers and liver centers. So this is a study again from China, where they proposed a cutoff of 7.7 to have a very good sensitivity and specificity to differentiate biliary atresia from non-biliary atresia. So these are the various markers. So now there is a plethora list of markers ranging from serum markers, IL-8, IL-2, interferon gamma, and intercellular adhesion molecules, microRNAs. Then there are studies on gene expression like RRAS, ankyrin repeat domain, secreted phosphoprotein. Then recently there has been interest on bile acid analysis. So this is so in this particular one of the study they mentioned the ratio of the glycoquinodeoxycholic acid is to quinodeoxycholic acid to have a very good sensitivity for prediction of biliary atresia. So among the serum markers, so there has been interest. There are several studies now on matrix metalloproteinase 3/7 in biliary atresia. So these in this particular study, they found that the levels were 7-fold higher even after doing a successful Kasai potentoscopy, and the levels differentiated biliary atresia from non-biliary atresia, and the levels correlated with the fibrosis grades. So this is a study on the basis of proteomics where the MMP level, when it was added to the GGT cutoff, so it had a very good sensitivity of up to 97% and specificity 84% and accuracy of 95% to differentiate biliary atresia from non-biliary atresia. So what about liver biopsy? So liver biopsy has a almost 95% accuracy. So it is still not a gold standard. What are the things we should look for in biliary atresia? So these things are bile duct proliferation, portal expansion. So portal expansion, what is mentioned as loose edematous expansion of the portal tracts by fibrosis. And there is portal as well as periportal fibrosis, bile plugs, and also sometimes you may find ductal plate malformation, which because in some of the cases the biliary atresia is part of the ductal plate anomaly. So this is the picture showing portal expansion on the mesenteric stain and also the ductular proliferation. So what about, so up till now we have discussed so how we can make the diagnosis postnatally, but most of these tests are actually done when the disease is actually beyond a certain level. So means around 6 to 8 weeks infant, but we have to target our diagnosis to within 3 weeks at the best of the centers. So there is now some work which has come up on direct bilirubin level at the time of birth or within first week of birth. So this is the study from Texas where 61 subjects with biliary atresia were actually enrolled, and they actually looked up their direct bilirubin and conjugated bilirubin levels in the first week of life. So 56% of these babies, they found their direct and conjugated bilirubin levels, and they found that their direct bilirubin levels were higher than those of controls. So 1.4 versus 0.19. So despite the elevated direct or conjugated bilirubin levels, majority of patients, like 70%, had a normal direct bilirubin to total bilirubin ratio of less than or equal to 0.2. So this ratio, we mentioned neonatal cholestasis definition as when this ratio is more than 0.2, when direct bilirubin is more than 20%. But these biliary atresia infants had high direct bilirubin, but their ratio was less than or equal to 0.2. So this is another work from the same group, and this is highly quoted and also published as a letter in NEJM. So where the 35 biliary atresia were compared to 9,000 non-biliary atresia infants, where their direct bilirubin and conjugated bilirubin levels were retrospectively looked up, and they found that if the direct bilirubin levels or conjugated levels are high, that has a very high sensitivity and a high specificity of 98.2% for prediction of biliary atresia. So this is another work again from US, but from a different centers. So this particular center looked up again more than 10,000 neonates, and they found the cutoff values for 95, 97th and 99 centiles as different cutoffs. And of the biliary atresia, the direct bilirubin levels were more than 1.3. That is more than 99th percentile within the first week of life. So it is possible that we can diagnose biliary atresia within first 1 or 2 weeks of life. But this effort should be at the neonatal or at the primary healthcare center level. So this is our data from ILBS till 2019. So here we can see that the commonest group of the neonatal cholestasis, the commonest etiology which we see is biliary atresia, followed by familial causes, PFIC, metabolic infections, multifactorial, and then paucity, syndromic and non-syndromic. So this is the work where we are in this cohort. We looked up how we can differentiate biliary atresia on the basis of transient elastography, and on the basis of a cutoff of around 8.8, we can differentiate biliary atresia from the non-biliary atresia cases. But again, we can see that the age group here are 0 to 3 months and 3 to 6 months, but we should focus our diagnostic strategy to within 4 weeks or within 3 weeks age group. So this is the chart which I think Dr. Yachha sir has already discussed. I would like to focus your attention on the left side of this chart. That is a baby with acholic or fluctuating stool color. We should immediately look for the ultrasound, to look for small or abnormal glider, to look for biliary atresia. We should subject the child to liver biopsy and look for findings of the liver biopsy, that is ductal proliferation, bile plugs, edematous expansion of the portal tracts with or without ductal plate malformation. And in this protocol, we have also now added, if the gallbladder size is around 10 to 19 mm, we can still avoid opening the abdomen. So peroperative, instead of peroperative cholangiogram, we can also do percutaneous cholangiogram. And I will discuss then this in the next scenario. So this is a case of baby S, who was 45 days old, referred from AIMS Jodhpur and admitted in NICU on 2 occasions, and the baby presented to us with clay-colored stools. So this was a late preterm 35-weeker, and the meconium stain with respiratory distress, birth weight of 2.1 kg. There was no history of any 2PN usage, but he had fluctuating stool color and no history of any decomposition. And there was early onset sepsis with a prolonged NICU stay up till 14 days. So this was the profile. We can see that hemogram was almost absolutely normal except for anemia. The baby had conjugated bilirubin with high alpha, with high GGT. Alphos was normal for his age, but GGT we can see that it was 208. So the metabolic workup which they did was negative, and then the ultrasound showed a gallbladder size of 18 mm and triangular cord sign was absent, and spleen was mildly enlarged. So liver biopsy was done, but again, as I already mentioned, that it was not very conclusive. The liver biopsy showed just intracellular and calenicular cholestasis with some inflammation, and there was no direct, just mild ductal proliferation was there, but this biopsy was done at around 4 weeks. So this was too early to comment on whether the fibrosis has yet developed or not. So this was the test which we did. This is percutaneous cholangiogram. We can see that the dye was the needle was injected into the gallbladder under ultrasound guidance and ultrasound as well as fluoroscopic guidance. And we can see here that there was patent biliary tree. The dye was going into the extrahepatic biliary tree as well as up into the liver. So we can again see this video that there was patency of the biliary tract, and this is the same thing which we do, which our pediatric surgeons do on peroperative cholangiogram. So in this way, in this baby, we excluded biliary atresia by demonstrating a patency of the biliary tract. So the possibility left with us was multifactorial or or it may be again cholestatic or metabolic causes. So now now in biliary atresia, what happens after Kasai portoenterostomy? So let's discuss the natural history of biliary atresia. So 30 to 40% may not actually totally benefit with Kasai portoenterostomy. In one third of the cases, Kasai may serve as a palliative surgery, and liver transplant may be delayed up to age of 2 to 15 years or even beyond. And in around 20 to 30%, these children may live jaundice-free into adolescence or to young adulthood. So what are the various modifiable as well as non-modifiable factors? These depend on the experience or the load of the center, which they mention as at least the center should be doing 5 Kasai surgeries per year. And also another most important modifiable factor is use cholangitis episode, and also the usage of prophylactic or IV antibiotics. Then non-modifiable factors are age at Kasai, type of biliary atresia, fibrosis, presence of ductal plate malformation, and also the size of ductules if they are less than 150 microns in diameter. So the natural history can be just divided into whether the child is having unsuccessful Kasai. So these children have rapid decomposition, portal hypertension, variceal bleed, development of hepatopulmonary syndrome, and infections like spontaneous bacterial peritonitis or pneumonia, and they require early transplant within infancy. The other group is successful when the bilirubin comes down below 1 at 3 or 6 months. So then a proportion of these successful may have recurrent cholangitis, again rapidly developing portal hypertension or decomposition, and transplant may be delayed up to 2 to 15 years. And another group is with infrequent cholangitis, where the portal hypertension is slowly progressive without any decomposition, and these children may survive into adulthood, which the figure is around 20 to 30%. So these are the various events post-Kasai, that is cholangitis, portal hypertension, variceal bleed, ascites, and pulmonary complications like hepatopulmonary syndrome or portopulmonary hypertension. So this is a busy slide, but we can understand here that after a successful Kasai, they may have recurrent cholangitis, which can again lead to decomposition and early transplant, or it may be refractory cholangitis, which may again become, the infection may be life-threatening, leading to the mortality as well as morbidity. And a proportion may have infrequent or no cholangitis, and these children may survive into adulthood. So long-term survival, 5 to 25 years after Kasai. So overall, so 1 in 4 or 5 cases, that is 20%, 20 to 25% of cases become long-term survivors. And even in the long term, they may have problems related to portal hypertension, variceal bleeding, cirrhosis, or cholangitis. And the predictors again develop on presence of cholangitis episodes, biliary flow after the Kasai, age at Kasai, and late disappearance of jaundice. So what about the indications in the absence of jaundice? That is in the long term, when the jaundice is not there, jaundice is totally cleared. So still some children may require transplant. So these indications may be portal hypertension, uncontrolled variceal bleed, intractable cholangitis, or growth failure. So bilirubin is the most important predictor. If you are able to control bilirubin, if the bilirubin comes down below 1, so that is the most important predictor for survival with native liver. So now coming to cholangitis. So this is the most important determinant for the long-term outcome, short-term as well as the long-term outcome in biliary atresia. So what happens? These cholangitis episodes are common 1 to 2 years, within 1 to 2 years of Kasai, and this is the most important determinant. And the mechanisms for cholangitis are bacterial translocation, or it may be a partial biliary drainage leading to bacterial overgrowth. There may be hepatolithiasis or increased interluminal pressure, which is going into the liver. So the gram-negative bacilli from intestine go into the liver, repeatedly cause cholangitis, and lead to development and progression of fibrosis within the liver. So what are the various strategies to tackle these cholangitis episodes? These may be like antibiotics, prophylactic, or IV regular antibiotics. Some people use preoperative bowel decontamination or usage of steroids to suppress the inflammation in that area, and also ursodeoxycholic acid or modification of Kasai portoenterostomy by surgical techniques. But these are again have not been proven to be effective, like lengthening of the Roux and Y loop or usage of an intussusceptive valve. So now I am just showing another case who is an 18 months old girl. So who presented to us, who was a cystic variant of biliary atresia at 2 months. So diagnosed and confirmed biliary atresia and Kasai portoenterostomy was done. So at day 69 of life, but subsequently she had recurrent cholangitis with fever and jaundice. She received intermittent IV antibiotics and then put on cyclic antibiotic prophylaxis, but came to us at 18 months with repeated episodes of fever, jaundice, and increase in bilirubin. So on examination, she had hepatosplenomegaly with jaundice, and growth was normal for her age. And on ultrasound, there were multiple intrahepatic cysts with some sludge. So we can see bilirubin was elevated and alkaline phosphatase and GGT were high for her age. Ultrasound showed grade 2 esophageal varices. So this was the MRCP picture which showed gross dilatation of the biliary tract, and this was and there was a suspicion of hepatostricture at the hepatocholangiostomy site. So impression was bile lakes. So bile lakes, as mentioned in the literature, are cystic dilatations of the intrahepatic bile duct, which are seen in around 18 to 30% of the cases. So what we do in this particular case? So she was started on IV antibiotics. So treatment modalities were explained to the parents. So option was liver transplant, or the percutaneous transhepatic biliary drainage was also considered because there was suspicion of stricture at the portoenterostomy site. So the portoenterostomy site was drained, a catheter was placed, and subsequently when the drain was placed, so the drain revealed multiple stones and the culture was positive for E. coli and Pseudomonas, and subsequently the drain was kept there, and the system and the biliary, the dilatation, when the dilatation collapsed, it was dilated with a balloon, and the stricture was subsequently internalized and then finally removed. So we can see here the bilirubin came down from 4.4 to 1.1, and ultimately after a period of 6 weeks of IV antibiotics, the culture became sterile. So what are the other options? Like prophylactic antibiotics, which we at our center are routinely using. We are using cyclic antibiotics, cefixime alternated with ofloxacin every 3 weekly. So for a period of at least 1 year after the last cholangitis episode. So other options are like ursodeoxycholic acid. There is a study from AIMS where they have used autologous bone marrow stem cell transplant, but overall outcome was not actually different in comparison to those who did not receive it. So then what about steroids? So there are numerous studies on steroid, including 2 randomized controlled trials as seen on the top 2 studies. And the studies have used low dose versus high dose steroids. So the studies, the randomized controlled trials have shown that, like the first study, which was published in the bilirubin, and but the serious adverse events in the form of cholangitis was slightly higher in the steroid group in comparison to the non-steroid group. Similarly, the study by Davenport, they showed that the bilirubin levels were different at 1 month, but there was no difference at 3, 6, or 12 months. And particularly in the less than 70-day age group, the bilirubin levels were different in comparison to the non-steroid group. So overall, there was no difference, but if the surgery Kasai is done in a younger infant, so then usage of steroids may be helpful. So what about probiotics? This is a study from China, from Taiwan, where they mentioned that the usage of probiotics, Lactobacillus casei rhamnosus, can help in improving preventing the cholangitis episode after the Kasai surgery. So by replacing the harmful microbiota with the good bacteria. So antibiotics. So this is the study on which our antibiotic policy has been is more or less based, like home intravenous antibiotics. So this is a study from Korea where they mentioned that 6 to 8 weeks of home intravenous antibiotics reduce the hospitalizations and reduce cost, and also improve survival with native liver. And there is also data on usage of IVIG in refractory cholangitis in reducing the febrile days and hospitalization. So this is our study, which was published in 79 post-Kasai biliary atresia, and overall success was in around 37%. And Yeah, and 27, that is 44% out of 61 survived with their native liver at 2 years. And we found that the lower age at Kasai and usage of post-operative steroids and absence of cholangitis episodes were the significant predictors of a successful Kasai enterostomy. So further, we looked up our cases of cholangitis, 86 biliary atresia in one and overall 128 cholangitis episodes, and we can see here the overall successful. So we in this particular analysis we excluded the unsuccessful Kasai. So 50% were successful and 50% were partially successful, and this was the overall incidence rate of cholangitis. This was 0.5 per person per year, and median age at cholangitis was around 6 months. So as we can see here, majority of the cholangitis episodes were within 12 months, and the response to first line antibiotics was just seen in 22%. And there was response to second line in around 41%, and around 37% did not respond to even second line antibiotics, and they were labeled ultimately as unsuccessful or as decompensated liver disease and listed for transplant. Recurrent cholangitis, that is more than equal to 2 episodes, were in around 57% of the patients. So overall success with native liver was found in at 1 year was found in around 66% of the patients. And the predictors were again early cholangitis, higher incidence of cholangitis per month, and non-response to treatment, and smaller portal vein diameter were predictors of poor outcome at 1 year. So this we showed that the portal vein diameter. So as there is more and more cholangitis, the portal vein becomes more and more sclerosed, and this leads to poor outcome, poor survival with native liver in these infants. And also we showed that if there is even a single episode per year, more than equal to 1 episode per year, so then that actually can drastically affect the outcome of these patients in the at 1 year as well as in the long term. So also we looked up our cases of refractory cholangitis, 12 patients where 6 of them had cholangitis abscess or bile lakes, and this is the protocol which we actually developed over a period of around last 6-7 years, that we initially start with piperacillin tazobactam, then we shift to meropenem colistin or to tigecycline and meropenem colistin, and ultimately we found that we could actually saved liver transplant in around 75% of our of these 12 cases, and ultimately liver transplant was required in three of these cases. What about portal hypertension in biliary atresia? So this is another scenario of a 2-year-old boy who underwent Kasai enterostomy at 72 days of life. So he had around 3 or 4 episodes of cholangitis in the first 2 years. And subsequently, beyond 2 years, he presented with multiple episodes of upper GI bleed. Upper GI endoscopy showed large high-risk varices, mild PHG, and he was put on EVL and followed by EST sessions. So he had growth failure, he had pallor and hepatosplenomegaly. And investigations, as we can see here, there was anemia with thrombocytopenia, which is due to hypersplenism, and there was high alkaline phosphatase and low albumin. And also he had moderate hepatopulmonary syndrome with high fibroscan value and a portal vein diameter, which was on lower side. So the portal hypertension, so as per various studies in literature, the varices are present in around 60 to 90% of the patients with biliary atresia, and gastric varices are present in up to 10% of patients of these patients. In the long term, when they survive beyond 10 years or till adolescence, again the varices rate is around up to 50 to 70%, and the bleeding rate range from around 25 to 30%. So what is the bleeding risk in biliary atresia? So the bleeding risk depends on the presence of gastric varix and on presence of the red color signs over the esophageal varices. So if the variceal hemorrhage is there and the bilirubin level is also very high, that is if it is more than 10, so then there is the overall survival of these children is just 50% at 4 months. But if the bilirubin is less than 4 and there is no bleeding, so then the survival is around 80% at 4 years. So cholangitis and portal hypertension are interrelated. So these are the long-term studies where we can see that the cholangitis is present in up to 30 to 50% and portal hypertension in around 50 to 90% of the patients. So this is a long-term study from King's, where they looked up the predictors of native liver survival in adolescents for patients with biliary atresia, and they found that the need for liver transplant at beyond 16 years of age is related to late cholangitis, portal hypertension, or presence of varices. So how they are interrelated, cholangitis and portal hypertension. So when there is early cholangitis, recurrent cholangitis, or refractory cholangitis and biliary atresia, it leads to inflammation in the region of the region of the porta, leads to inflammation of the portal vein, so which ultimately gets sclerosed, and which leads to progressive portal hypertension, and this portal hypertension ultimately leads to poor survival with the native liver. So there are studies in literature that portal vein sclerosis ultimately is not good even before transplant. Even it can affect the after transplant outcome in terms of need of portoplasty, and also there is more risk of development of portal vein thrombosis. So this is data from our institute on 86 children where 69% had varices, and predictors of portal hypertension at 2 years. So out of all the predictors, we found that early cholangitis, lower platelets, and also lower portal vein diameter was related to development of to presence of portal hypertension. So and this portal vein diameter, as I already said, that cholangitis is frequent, so then the portal vein diameter goes down. And also if the cholangitis is early, that is within first year of life, then again the portal vein diameter is low, and which leads to rapidly progressive portal hypertension, and thus affects the survival of these children with native liver. So finally, I can conclude my talk by saying that biliary atresia needs early diagnosis and surgery. So diagnosis is based on looking up the stool color, looking up the conjugated and direct fraction of the bilirubin, and an ultrasound by a trained radiologist, and a liver biopsy. And after the Kasai surgery, these children need regular surveillance for cholangitis and portal hypertension. And we should remember that 20 to 30% survive with their native liver till adulthood. So we should try our best to help these children survive without liver transplant. Thank you.
Thank you, Dr. Rajeev. It was a very extensive talk for as a pediatric surgeon is concerned. Maybe for a gastroenterologist, maybe okay. You know, surgical peoples are a bit different. But just I want to highlight some of the things. The final outcome in our institute is also only, I mean, without liver transplant is only less than 20%. That you also highlighted. And what happens is that most of the time, at the time of surgery, we know what is happening. The triangular cords, and as you explained in ultrasound, we don't see any fibrous tissue at all at the porta. Sometimes it's totally blank. There won't be any site for anastomosis at all. Things like that happen. And we know what is the final outcome in such situation. Another situation which we face is that extreme preterm, 26, 28 weeks babies, they come with the issues. Probably we think it is drug induced or parenteral nutrition induced. And several of them may recover from it, but we may not be sure at that time whether we have to label them as biliary atresia. Can you have an advice on that?
Sorry, Dr. Sivakumar, your voice, so I could not hear you properly, but what I can understand that you were asking about if the baby is presenting within 3 to 4 weeks of life. Is that your question? And the baby is on preterm baby, yeah. So that is actually a very common scenario. So in preterm, or those babies who just recovered from sepsis. So this actually what we label as multifactorial cause of neonatal cholestasis, where there is interplay of multiple factors: prematurity, sepsis, small for gestational age, and also TPN usage. So all these 4 factors contribute to development of cholestasis. So sometimes it becomes difficult. So the same scenario I showed also in one of the case who was referred to us from AIIMS Jodhpur. So where we even did liver biopsy at around 4 weeks of life, but the liver biopsy was not conclusive. There was no significant fibrosis, and the ultrasound was also not totally suggestive of biliary atresia. And in that scenario, we took up the baby for percutaneous cholangiogram. So in some of these cases, the patient has to be taken up for means for final diagnosis for confirmation. These tests must have to be done. But as Dr. Yachha also has pointed out in one of the case scenario which sir has shown, that with such a scenario, the first possibility will be means the first of all, as biliary atresia is the commonest thing, that actually should not be, and there is need for early diagnosis and early intervention. So that should be considered with the high index of suspicion. And then the second possibility should be considered as multifactorial.
Thank you. That is what we face also. It is open for discussion. Talk is open for discussion. Any questions from the floor? I would like to add one more question. Sometimes we lose the baby in the immediate post-op period. They develop acute liver decompensation. They go for a very acute hepatomegaly, hypertension, then sudden elevation of the enzymes. Can you explain the situation, why that happens?
Yeah, Dr. Sivakumar. Post Kasai, the ascites, that actually is a very common occurrence. So the drain has to be there. So which we also feel, and the drain fluid, whatever comes out. So for few days, we have to replace the drain fluid, whatever is coming out, with 5% albumin. So that is actually a common occurrence. And for a limited duration, for a week or so, these patients also requires small little dose of diuretics also, just to clear the fluid. But the decomposition part, which you are saying, that I can actually attribute to cholangitis. So cholangitis actually also is a common occurrence in our setting also. Sometimes it may be a hospital acquired infection. The babies go to the OT, and from there they may acquire some hospital acquired bug. And sometimes it is very difficult to treat that bug also. And they may have prolonged hospital stay. So means just this needs high index of suspicion for sepsis, as well as for as well as for this post Kasai, means like for secondary bacterial peritonitis also sometimes which may happen.
Dr. Prashant, can I ask a question?
Yeah, please go ahead.
I don't know whether you can hear. Dr. Rajeev, thank you. I have 3 questions. One was for cystic type of biliary atresia. Should we upfront do liver transplant? Because you know that cystic type of BA, they don't do well. Maybe that was the reason they had issues. What was your take for that?
Yes, ma'am. Ma'am, actually cystic variant means there is the literature is actually not very clear. Means like you have said that the cystic variant may have poor prognosis, but some studies even have said that cystic variant may have a good prognosis. So the Kasai surgery should actually be offered, because if we do liver transplant at 2 months or 3 months, again the outcomes may not be very good. The success rate will be around 70% even at the best of centers. So
because even in our case, we had one cystic diagnosed much earlier, because the cystic type, you pick it up even as antenatal, and then they didn't do so well. And it was very sad. We did it in the newborn period, and then the results were not good. That is why I was asking. The second one I was thinking was, in biliary atresia, we always say the GB will be collapsed. So doing a percutaneous cholangiogram is difficult. So I think if you get a good GB on ultrasound itself, definitely, probably you can exclude, and even a PTC may not be necessary, because unless you have a good GB, a dilated GB, doing a percutaneous transhepatic cholangiogram itself is so difficult in a collapsed GB.
Dr. Rajeev?
Line got cut.
I think he has lost connection.
Okay.
Your
I think
concerns
Dr.
are right, madam.
Yes, I think Dr.
Concerns-
Yachha can also, it's difficult, percutaneous. If your GB is not, it's contract, that you use it as a sign for PA.
Your question is very valid. I don't advocate this.
Ah,
I don't do this percutaneous game. Second
okay.
thing, intrahepatic radicals are generally sucralose.
Ah,
In biliary atresia, we don't expect any dilatation. We don't expect good ductal size. We
that's what,
don't expect then good success also. So
yes.
therefore, percutaneous cholangiography I would not do in these cases.
Yes, even I feel maybe it will not pick up. The third one is also, I'm always concerned about fibroscan in biliary atresia because I always feel it will be more than F2, F3. But anyway, studies are coming up, but I don't, because we call it as an obliterative progressive dynamic disease. So the fibrosis is already there even at the time when we take it up for surgery. So
Even at
very,
birth, actually they have fibrosis in utero. They're always, even at the birth or post-operative, post-neonatal period, they will have always fibrosis. Fibrosis is always there. Hepatomegaly will persist despite successful Kasai. Splenomegaly will also persist. It is not that will regress following Kasai surgery. That will persist. Fibrosis is always there. Universal phenomenon in biliary atresia.
So the cutoff of 7, I was thinking was little low, maybe much higher. That's what I was thinking.
Don't need to go for unless we are doing research protocols.
Yes.
So in practice, it is not required to be a fibroscan and all those things are not required. We should be very practical, as our pediatric surgeon has said. That what pediatricians need to know about biliary atresia, that should be actually taught to them. That's all. Regarding your cystic variant, am I audible?
Yes, sir. Yes, sir. Audible.
Regarding the cystic variant, I think cystic variant is bad actually. There are two conditions which are very bad in biliary atresia. One is cystic variant, and another is if you find biloma, you find a cystic dilatation within the liver, that is bile filled. That's a very bad thing for biliary atresia. For cystic variety, the only advantage, or we can say disadvantage, we need not to do biopsies in all cases. Cystic variety, when seen on ultrasound, you are distinct and clear, then you may not do biopsy. This is my feeling. Now, this is always biliary atresia.
Sorry, ma'am. There was problem with the connection. Ma'am, as sir has said that bile lakes actually we are seeing post Kasai potentoscopy.
Yes.
So in our almost, I can say around 10% of the patients develop bile lakes, and these one of the case I showed also. So we are managing with prolonged IV antibiotics, and in some of the cases we are managing with IV with the percutaneous drainage. And in one of the child we tried for stricture dilatation also. So which I showed. And in a small proportion, like sir has mentioned, that in some of the cases these bile lakes are seen even in the pre-transplant setting. So like that actually almost is like a cystic variant, or what we can call bile lakes.
Very different.
So it is almost similar.
Yes, Dr. Malti.
Yes, sir.
You shed light on other aspects.
Yeah, that's what we were asking. So I was asking regarding the fibroscan also, because I think your cutoff and levels should be completely different, because normally itself you'll have fibrosis, that thing, biliary atresia they will have. So how do we do? It's not the usual F0, F1, F2, but should we do it for all children? I think the pediatricians would like to know that, because fibroscan is now available everywhere, but what reading are we going to give, whether it will help, not help, because you're given it in the thing.
Dr. Rajeev has the answer. He is doing a lot of fibroscan. Yes.
So actually what we have found the cutoff around 8.5, but from the Chinese from the Taiwan study, they mentioned 7.7. So, but in our cohort, what I believe that the most of the patients were actually slightly delayed. Most of the patients are between 2 to 3 months of age. But from Taiwan, so we have to have more data on younger infants. So if we have data on under 6 weeks, 6-weeker infants, so then actually it will be helpful. If we are doing late, then it may not be of help.
What are the indications of doing fibroscan in biliary atresia? Should it be done routinely or it should be done in a special situation?
Yes, sir. So I will not say, because we have done in a lot, means almost around 300, more than 300 infants. So, but I will not say in each one of them, because still we have to depend on the diagnostic flow chart, which you also mentioned, that we have to again go by the same things: stool color, GGT, and again that thing, liver biopsy. So we have to again depend on the same thing.
Right. Okay.
Did you have any case suspected biliary atresia, was Kasai done, and then they didn't improve? Even the report came like biliary atresia. Then when you start doing it, became prefix 3, because I had one child because it did not. Should we do bile acids and work up for that? Very similar picture.
Yes, ma'am.
Histopatology.
Yes, ma'am. It is mentioned in the literature that some of the alleles may actually turn up with Kasai, allegil syndrome. But for PFIC3, because PFIC3 is not a common, PFIC3 do not commonly present as neonatal cholestasis. Of our group, we have seen in the neonatal cholestasis just 1 or 2 cases of PFIC type 3 presenting as neonatal cholestasis. So that is actually a very rare thing, but allegils definitely should be considered.
Correct. Right.
Thank you, Dr. Rajeev. Thank you.
Thank you, Dr. Rajeev.
Sir, can I ask a question, sir? Shivakumar, sir, I am Dr. Binesh from Calicut.
Yeah, if there is time, it's okay. It's up to Prashant.
Rajeev, sir, it is an excellent talk. Sir, I have a doubt regarding steroids in the postoperative period. Would you advise to start the steroids very early, or maybe after 2 or 3 weeks, suppose the baby is having cholangitis, then we'll start, or we'll advise for all patients, for all babies?
Yeah, this is actually a very difficult scenario. So that's why actually we are not having a proper studies on steroids in biliary atresia. Just 2 randomized controlled trials are there in literature. But at least as per our experience, or even Dr. Yachha sir can also throw light on this, we have to wait at least for 7 days for the post-operative recovery. But because 7 days will actually, the picture will be clear if the patient is going towards infection or not. So then we can try steroids. And again, the dosage and how much and the duration also, that also is variable as per different literature. But if you are starting steroids, so then the same 2 mg per kg should be given. But some centers are using very high dose, even methylprednisolone at 4 mg per kg, that also is being used. And but the standard which is used by most centers like King's is for 6 weeks steroids. Start by 2 mg per kg and start tapering around between 2 to 3 weeks, and then stop by 6 weeks.
Okay. And when we are starting steroids, we used to give antibiotics prophylaxis for all babies. And is there any like increased incidence of cholangitis we start steroids, anything like that?
Yeah, means that actually we should be very careful. The surveillance for cholangitis is the most important key in the management of biliary atresia. So if you are starting steroids, then you have to be very cautious that the patient may land up into cholangitis. You have to continue with IV antibiotics for at least 2, 3, or even 4 weeks, because now most of our biliary atresia are being managed with prolonged IV antibiotics. That's how we are actually preventing as well as managing cholangitis episodes.
Thank you, sir. Thank you so much.
Dr. Prashant, shall we conclude?
Prashant mute aane. Dr. Prashant mute aane.
Yes, madam. Dr. Rajeev, how long should we continue the cholangitis prophylaxis post Kasai?
Yeah, Dr. Prashant, cholangitis prophylaxis, which we are using means once the cholangitis is under control. So that's what I mentioned in my talk also, that what we are using is cyclic antibiotics. We are using cefixime and ofloxacin alternated every 3 weekly. So it is at least 1 year after the last cholangitis episode. So which is a bit prolonged, means most of the centers in the world, they are using 3 months or 6 months, but we are using bit longer. But still there is no randomized control trial, no comparative study to use prophylactic antibiotics, oral cyclic antibiotics or not.
I think there are no more questions in the chat box. Priya sir is around. Priya sir. I think we had an interesting session today, run by Yachha sir and the other by Dr. Rajeev Khanna. The IAP actually is very keen. The IAP state branch is very keen on devising some strategy for the early detection of liver diseases. And as part of that, it was proposed that they'll try to include the stool screening chart in the MCP card. We are going to put forward this suggestion and take up the matter with the government. And over to Dr. CB.
Very good initiative, Dr. Prashant.
I'll just share the logo which was released by Dr. Sivakumar sir, who is our state president. So it's a presidential action plan is called a Promise, and preventing pediatric NAFLD is one of the programs, one of the projects of one of the 22-point projects of his presidential action plan. And this will be the logo which will be used in further meetings. Okay. So I would just like to show our gratitude to the logistics partner of today's program, that is Reddy's Ventura Group. And I would like to extend my sincere thanks to the zonal manager, Dr. Kasturi Rangan. Okay, over to Dr. Prashant.
I think we have reached the end of the session. May I call upon Dr. Benno to propose the vote of thanks.
Thank you very much, Prashant sir. It is indeed my privilege to have been asked to propose a vote of thanks. On behalf of IAP Thiruvananthapuram and Division of Pediatric Gastroenterology, Department of Pediatrics, Government Medical College, Trivandrum, my wholehearted thanks to the honorable delegates who have taken out their valuable time from their busy schedule. I would like to express my sincere thanks to the most respectable Professor Dr.SK Yachha sir for giving us a detailed insight about neonatal cholestasis and about the most recent advances and all the important aspects of it. And I'm very grateful to our beloved Madam Dr. Elizabeth for chairing the session. Next, I would like to express my profound gratitude to Dr. Rajeev Khanna for the excellent presentation on biliary atresia and all the practical aspects. And I would like to thank Professor Dr. K.E.Elizabeth sir for chairing this session. And both the sessions, as Dr. Prashant had said, it was very interactive and enlightening for all of us. My sincere thanks to Dr. Prashant sir for coordinating the whole session. Next, I would like to thank Vijayakumar sir, IP State President, Johnny Sebastian sir, IP State Secretary. And next, I would like to thank our National EB member, Riya sir. Special thanks to Praveen sir for coordinating the Zoom session. And last but definitely not the least, I would like to thank all the audience for the patient listening. Over to you, Prashant sir. Sir, mute Anna.
I will hand over this Dr. CB for some technical reasons.
Shall we disperse the meeting then?
Just 1 second, madam. Yes, we have reached the end of the session. Heartfelt thanks to Yachha sir as well as Dr. Rajeev for enlightening us today.
And now over to Dr. Rukmini madam for the final conclusion.
We'll disperse the meeting then. Thank you, everybody.
Thank you very much.
Thank you, Yachha sir. Thank you, Rajeev Khanna sir. Thank you, Sivakumar sir. And a special thanks to Praveen and Prashant.
Thank you, ma'am.
Thank you. Thank you very much.